Hello to everyone who's on our call today. Welcome to the CMDA monthly meeting. I'm Singh Pallet, the president of CMDA, and our board member, Dr. Chris Horton, will be hosting today. So Chris,
Hi,
go ahead.
everyone. Welcome. Thanks for attending a busy day. We're just going to dive right in. We have a really exciting agenda today. So we'll start with Jenny Albertson to give us the CHCA updates if she is on.
I am on. Can you hear me all right?
Yeah. Do you want me to pull up your slides?
Yeah, I sent the slides.
Yeah.
Can I ask if everyone else, if they could mute? Maybe Val, could you mute, please? Thank you.
Thank you for giving me a minute here. I'm just going to give you a couple of high points that are pertinent information for you all. My next slide, please. My first note comes courtesy of Doug, our president and CEO. He is wanting us to kind of be aware of the things on the horizon with the governor's budget, because there is going to be an impact to elder care, long-term care, and assisted living. So you may know and be familiar with our Tabor law. And part of what goes with Tabor is that when we do a budget, we have to incorporate our inflation factor. And it's actually now below the national average. That's kind of amazing. Oh, can you go back to the slide that was there? Thank you. And our population growth is also down, and it's our lowest in the past 10 years. So both of those things are making it so that we have to compress our budget in order to be in compliance with the Tabor amendment. And so we're a little nervous because healthcare and Medicaid spending is one of the biggest line items in the governor's budget, in any budget. And so when the governor proposes a budget, it goes through a lot of iterations. This is just kind of a baseline platform of what he wants to support and what his office is listening to from constituencies. And so one thing that he said is he's not going to touch our Medicaid incremental increase to try to account for inflation, which is 1.5% increase. So that is not going to change, it looks like, as long as the governor's budget goes through as recommended. Next slide, please. The other component to this is that assisted living is being targeted by a lawsuit that we've been working on settling with the Department of Justice for many years now, and we have just reached a settlement. But in the settlement, the Department of Justice makes really clear that they believe that assisted living and other potentially funded levels of care have been neglected while we have continued to receive funding increases for long-term care Medicaid, which is in fact true. But if you look at the ceiling being pretty low to begin with, and the funding being egregious for the long-term care side, we only receive about 80% of our costs reimbursed through Medicaid funding, then it kind of looks even worse for not funding assisted living and other levels of care, right? So we agree with them, although it's a skewed representation. So bottom line is the governor's office is entertaining implementing a tiered reimbursement structure for assisted living Medicaid beds, which would not overall increase the reimbursement that assisted livings get for a Medicaid resident. Right now, it is like $90 a day. It's very minimal. And it's basically a supplement, and then the individual has to pay privately for the rest of their care, which is why you don't see Medicaid assisted living like you do for long-term care. Bottom line is, they do want to do a tiered structure to account for different types of care that's being provided in assisted living. So that's good news. Also, they are looking at an increase in funding for the PASAR program, which would be lovely because right now it shuts down on the weekends and you can freeze an admission. A resident can be stuck in a level of care that they shouldn't be stuck in because of waiting for the bureaucracy of PASAR. So we'll see what happens with the budget, but that's a snapshot for you. Next slide. All right, and just a quick reminder on the flu vaccination requirements. So skilled nursing and hospitals are required to have, and assisted livings are required to have vaccination offered to their employees. We do have to have a 90% compliance rate reported. So as medical directors, you're going to have to push, if you haven't already been doing so, to get your staff folks compliant with the flu vaccination requirements. Quick note, religious exemptions are not permitted for flu vaccination. In our statute, it is exclusively a medical exemption. So if people ask, it's not something that you need to account for. It's either a medical exemption, which there shouldn't really be very many, or they get the vaccine or they refuse to take it and they end up with masking throughout the rest of the flu season. And I'm not sure if it's in this slide. I will send and make sure that you all have the clarification for the dates at which you need to have people masked through which period. Unless someone else can put it in the chat, that'd be great. Next slide. This kind of slipped through the cracks a little bit when they updated the mitigation guidance. They did update the definition of an outbreak. So when you're looking at cases of COVID in your communities, staff being tested positive should not trigger an outbreak report. It should trigger an investigation and see if you do have it present in your resident population. They've changed it so that outbreak has to be resident cases, not staff and resident cases. You do still, however, have to clear all of your staff cases to clear an outbreak. So they did adjust that in the definition. This goes into greater detail on it for your reference. And next slide. That might be the end, actually.
I'm clicking, nothing's happening.
Okay, so that's probably my last slide.
Here
Thank
you
you
go,
so
sorry.
much. Oh, last tidbit. While we're talking about COVID, they have changed our NHSN reporting rule, and they've consolidated it now into flu, RSV, and COVID reporting all in one. It's simplified, and it looks like it's going to be in perpetuity. So our staff are still going to have to routinely report for NHSN. My hope is that they will remove the automatic civil money penalty and survey citation that happens when there's an error or an omission in the NHSN reporting, but we haven't received word on that yet. At least this is a simplification and a little less onerous. So there's a lot of detail there for your reference. And I think that may be my last slide.
That is.
All right, thanks.
Thank you, Jenny. Next up, we have Chad Fear with the Department of Health for updates.
Yes, good afternoon. I'd like to share just a couple quick slides if I could.
Absolutely.
Okay, yeah, I just wanted to mention we met with nursing facilities earlier today, and I shared some of these statistics. This is for a federal fiscal year 2024, which ended September 30th. So in comparison to the findings, citations that we have in Colorado when compared to the nation, I think you can see kind of across the board, and things get in a different order, if you will. These are in rank order, but they all fall pretty much within the same basket of citations, if you will. The citations that are most commonly cited are those that have multiple requirements in terms of compliance. So you can see there's, of course, many things that we have to do to meet the regulation, and therefore the citation rate for those areas are going to be higher. I looked at citation frequency. For Colorado, this slide is about Colorado, and looking at the number of citations that were given, the percentage of providers that were cited, and the percentage of surveys where deficient practice was cited for these particular areas. And I think you can see here that the percentage of providers cited is higher than the percent of surveys cited. So what that tells us is that there are facilities that receive multiple citations under these particular areas, particularly when looking at the infection prevention and control program, accident hazards, Abuse stands out significantly, food service, so that non-compliance at those facilities is a pattern, and is something that those facilities should be working on to to change those practices and sustain the corrective practice that they put into place. I also took a look at the common types of complaints that we received in federal fiscal year 2024. And these are not in rank order, but they do kind of rise to the top in terms of commonality. And you'll see issues around discharge, staffing, choices, physical abuse, environmental concerns, including temperatures and pests, wound care, concerns related to weight loss, and these concerns are coming from the community. So residents themselves, family members, or other community agencies are calling in these complaints to our office. Medication's not available, or residents being over-medicated. Falls with injury is a frequently reported concern, as well as weight loss. And along with that, showers, hygiene, and ADL care. We tend to see those three in complaint allegations most frequently. Untreated pain, notifying of change of condition, whether that be notifying the family or making sure the physician is notified of changes of condition, is something that we also see in terms of allegations in complaints. And then outbreaks. Whether that be, most commonly, it's COVID outbreaks being reported to us. Sometimes we see some other things, but typically that's COVID-19. So in terms of what I have for you today, that concludes my report. And if there are any questions, I'd be happy to take them.
Chris, I think you're muted.
I don't see any questions in the chat, but if you have a question that comes up, feel free. I think we're going to move on to Telligen with Courtnay Ryan. And
hello, good afternoon, everyone. Thank you. I was just going to ask, do you mind pulling up my slides? And you are on it. Thank you.
Here, I believe.
Perfect. Hope everybody's staying warm today. So I just wanted to share with you a new tool that was recently developed at the request of nursing facilities that folks might find helpful in their efforts to monitor psychotropic medication use. If you can go to the next slide, please. We have developed a tracker in the form of like an Excel spreadsheet that upon data entry will auto-populate some summary information and data visuals to assist long-term care facilities with monitoring psychotropics and GDR efforts, which support regulatory compliance and then also assist in identifying trends and opportunities for improving quality of care. So you can see here on the slide the various data elements that can be collected using this tracking tool. So you can track number of residents on psychotropic medications, residents that are on more than one, documentation, non-pharmacologic interventions, again, GDRs. You can track other diagnoses that may be of interest, IDT consults that are happening, and then also psychotropic discontinuation. None of the fields in the Excel spreadsheet tracker are required to enter in the data, but they're just meant to be there for you based on your needs and what you may want to be tracking. As I mentioned, this is really hot off the press. We just released this 2 days ago. So other than the comments that we've had from the reviewers that tested it, we have not had time to see any outcomes from the homes that are using this yet, but we'll certainly be keeping tabs on that so that we can hopefully demonstrate some improvements where they may be needed. Next slide, please. In terms of some of the regulatory requirements, and I'm always thankful when we have chat in the room in case there's questions around these, But you'll note there's two listed here. So we have the F757, which is the freedom from unnecessary drugs, and F758, which is the freedom from unnecessary psychotropics. Often the two are cited together, and in some situations they're also linked to other regulations as potential tags. So if folks are concerned about these areas, this tool could really help support with meeting some of the components of those regulations. We also wanted to give just a few ideas to consider as it relates to CWAPI, if you're working on either maintaining or improving your documentation and processes around unnecessary medications, or perhaps psychotropic medications, or maybe even just overall medication regimen review. So I put a link here to the critical element pathway for these areas. These are excellent tools to share with the team that serve as kind of like a checklist to assess how you're doing and identify any gaps that you might want to mitigate to avoid tags. And then also provided some questions here for you to just consider or think about as you're having those different psych FAR meetings and CWAPI meetings and other discussions. So there's also a link to the tool as well. If you go to the next slide, I think that's my last slide. And I think I shared this update last month, but our current QIO contract ends this Thursday, November 7th. So I encourage you to go ahead and download that tool and check it out. If you have any questions, our team is available through the end of the day, Thursday. And then just to continue to please be on the lookout for our information that we receive, and we'll send it out through our constant contact and through emails and through LinkedIn. So hopefully we receive some information around that notice of award for the QIOs, and hopefully we receive information at Telligen to continue to get to support you all. So thanks so much for giving me some time to provide updates on this tool, and I can stick around if there's any questions.
Do we have any questions? Great. I think we had Dr. Gahm is next, but we will move him to the end. We have an exciting presentation on something that I know everyone is interested in one way or another. I'm actually going to have Dr. Pallett introduce our next speaker. She has a connection, and I'll let Dr. Pallett.
Oh, no, I'm so excited to introduce my friend and colleague, Ben Canter. He's an occupational therapist, and he is a PhD student at Boston University. He has many published works, and he is a member of PALTC. Ben and I have worked together on the Transitions of Care subcommittee for PALTC for several years. We're so glad to have him today. He's going to be talking about my PALTC patient wants to have sex. Now what? How rehabilitation can help.
Yeah, thanks, Sing. Thanks, everyone. I'm thrilled to be here with you all. I'm going to share my screen. It's great to be here. So like Sing said, I'm an occupational therapist. My background is in geriatrics. I've been in the geriatric space for like 10 years now. Basically, I'm going to be talking about what to do when your patient wants to have sex in a post-acute long-term care setting, which I know is something, it's a big topic. And so today, we're just going to take a small bite out of this larger pie. I don't have any conflicts of interest. So why are we talking about this? There are actually few state or federal policies around sexual activity. And so a lot of times it falls on the physician or sometimes an NP to assess or, the physical safety, and then sometimes on psychologists and social workers as well, the physical and like psychosocial safety of sexual activity for residents. And so just take a minute and think about like, what are your criteria for functional, okayness, if you will, for sexual activity, and if you feel confident assessing that. So what the learning objectives are today is we're going to focus specifically on a type of activity analysis, which is a tool that occupational therapists typically use to assess complex cases of sexual activity. function and how those things can kind of come together in a patient case through case studies. And we're going to figure out when is it a good idea to refer a client to a rehabilitation clinician for sexual activity in post-acute and long-term care. So like I said, this is a huge topic, and today we're going to focus specifically on function and how function and sexual activity and your role as a provider all can kind of come together and hopefully create a successful experience. So in quick introduction and overview, I'm actually going to start a timer for myself here because I don't want to go over. And basically, sexual activity is an ADL, and it encompasses a lot. Any kind of sexual expression, hugging, kissing, foreplay, masturbation, oral sex, intercourse, all of these things are a type of sexual expression and could be seen as sexual activity. And it is an ADL formally under the standards and framework that we know as rehabilitation clinicians. And so quickly, there's about 65% of older adults who report that sex is important to them and their quality of life. And 8% of nursing home patients said that sexual intercourse was a part of their life in the preceding month, which is a lot higher than we might initially expect. And sexual activity, while more challenging in older populations, is not actually contraindicated by many of the conditions that older adults face. And so sex can be safe to engage in sexual activity in some form because it can always be adapted. And that's what occupational therapists and other rehabilitation clinicians kind of specialize in. And so hopefully I'll give you a taste of how you can use similar thinking to the way that we as rehabilitation clinicians think. So an intro, as we're going to use going to the bathroom as an example. Toileting is a classic thing that OTs, PTs will work on. Right? And so there are all of these steps to going to the bathroom. And as OTs, we break these steps down. First, you have to recognize you need to go. You need awareness. You need to have an intact nervous system. Then you need to get to the toilet. You need mobility. You need sight, right? You have to place the toilet paper. You have to remember to do that. Then you need to get the toilet paper. There are all of these steps and sub-steps and sub-sub-steps that make up an activity that is otherwise easy, like toileting, right? And so we break these things down for individuals who might struggle to get through certain parts of the task so that they can then complete the whole task as independently as possible. And we use what's known as the PEO model sometimes to evaluate that. And we can use that here for sexual activity as well. So what is occupational performance? That's when you can do and accomplish an action that you want to do and perform it successfully or not so successfully. And it's an interaction between the client, the context or the environment, and the demands of the activity itself. So you can see here, you have these person factors, the P, and then you have these environmental factors, the E, which is like where the nursing home is, who's there, who's around, what's the environment like? And then you have the occupation or the activity, which is what are the demands? What do I need to do to accomplish this task, right? And by taking this approach and thinking about what I need to do and what I have at my disposal in the environment and my own skills, that can help create a better picture of what does this patient need to be successful, to perform this task of sexual activity well, right? So we'll start with a pretty basic case study here. So these are all, by the way, cases, I changed the names, but these are all cases in quotes from patients that I've worked with at the skilled nursing facility that I'm at. So Sylvia is 88 years old. She's single. She's got some comorbidities, and she's on some medications for those. She has epilepsy, so on epilepsy medication, osteoporosis, osteoarthritis, depression, and she lives in a SNF. In a small house model unit with a roommate, and she has a personal aide that comes a lot of the time. And she had the pain in her hand makes it difficult for her to feel any kind of sexual pleasure. And she's afraid of these people that are in her space, Karen and Amy, her personal aide and roommate, but she still wants to feel good through sexual activity. And so what can we recommend for Sylvia? This is going to be a little interactive. Does anyone want to put anything in the chat that they might be thinking? I can't actually see the chat. I'm now realizing while I'm sharing my screen, but shout it out if anyone has any ideas. No?
Nothing in the chat yet, Ben.
Okay. Oh, I see.
We have
Okay.
somebody asked a vibrator.
A vibrator. That's a very good suggestion. So we actually think that a vibrator is a very good idea. And what we may need to do because of that arthritis, thinking about the person factor, is find an adaptive vibrator. So there are these vibrators here you can see on the right that can either strap onto the patient or be put directly on a bed so the patient can lie down on that vibrator and experience that kind of same sensation without needing to use their hands. So, because if we go back here, we can see that there's bilateral osteoarthritis in the hands, right? So thinking about those person factors, what are the limitations and what strengths does that individual have as well? We also might need assistance placing that vibrator, and we might want to work around that environment, right? Okay, they're here 4 hours a day or 4 days a week. When are they not there? So that maybe that's the time when Sylvia is more comfortable performing this activity. So thinking about that environment and thinking about her skills and how those things can come together to perform the activity. Education for the other people in the environment, the CNAs and nurses, maybe they're the ones who have to place the device, right? So educating them on why this is important for this patient and their quality of life. That sometimes falls on us as, the medical professionals, not that, a CNA or a nurse isn't a medical professional, but they oftentimes look to, the medical director, which I'm assuming many of you are, or, a nurse with more education than they may have for advice on how to deal with the situation such as sexual activity that may be unfamiliar, right? And so education is a really important part of this, right? Finding that quiet space when no one else is really around. And then maybe there's a do not disturb sign and you can close the door. Or if you can't close the door, maybe it's like ajar, but there's still a do not disturb sign, right? So just having that do not disturb sign can also help preserve some dignity. And we want to be thinking about that as well. And then a social work consult, because she's afraid of her roommate finding out, maybe there are some other issues going on as well, right? And so asking about sexual activity can also kind of give you a window into the rest of how that person is feeling, or vice versa, right? So then we want to kind of discuss recommendations with Sylvia, right? We want to reassure normality and validate her emotions. We want to explain the reasoning beyond just the recommendations. And we want to use a strengths-based perspective. So what does that look like? Well, this thing, sexual activity or masturbation, may be difficult for you due to your osteoarthritis because it puts you at risk for increased pain. You're still able to engage in this activity by using a vibrator and lying down on it, or by doing it outside of these hours when your personal aid isn't around. It's not exactly the same, and it might not be when you want, but this is still an opportunity for you to do this thing, right? So reframing is a really important thing when addressing something like sexual activity that is really integral to people's identity and well-being. So now that's a pretty basic case because there's one person. Now we can make it a little more complicated and have two people, like in this case, Johnny and Harriet. So Johnny is 77 and has had a hip replacement day 2, and he's really worried that, if he doesn't do something now, he's gonna lose his sense of masculinity, and his wife is gonna be really frustrated with him, right? This is a common situation where independence and sexual activity and masculinity are linked, especially in the older population. And so Johnny has similar comorbidities. He also has orthostatic hypotension, and he has osteoarthritis in his knees. And so thinking about that, he uses a wheelchair, and they're in an assisted living facility with Harriet, who doesn't have as much going on medically, but she may have some balance issues, right? And so thinking about, this is a quote that this patient said to me, that he wants to make sure he's still a man, right? And so what's behind that is a sense of independence, loss of independence, and loss of function, right? And so how can we help this couple do that? And so I have some fun little images here foreshadowed for you. And so the first thing that we want to really note are any kind of thrusting motions or hip precautions that typically come with sexual activity, right? And since they're in an assisted living facility, maybe they're not as, surrounded by supervision. And so it's important to consider that they be really educated on those precautions. Sitting positions should also be avoided, but what that can kind of leave you with is positions where Johnny may be laying down, right? And so reframing that as, hey, these positions aren't great, but that leaves you an opportunity to do these things with your partner, right? So that kind of reframing is really important when communicating about sexual activity with your partner, or with their partner. And then there might need to be some transfer assistance as well, unless he's already in a bed or the chair, wherever the sexual activity is going to take place. And bed rails can help prevent falls off of the bed. Lubrication is also really important because of any kind of vaginal dryness that may occur, which, if you go back to the case, is something that was presented there that Harriet had. And then, like I said, are they living independently, and what effect does that have on how they can kind of go about this, right? So thinking a little bit about that. So lying down is a really good position. And if you look here, and given this case, it looks like oral sex may be preferable in this instance, right? And so we can use that same template. This intercourse may not be best right now, given your medical condition, but there's an opportunity to do this other thing. And even though it's not the same, we can kind of get there eventually once you're feeling better, but this could maybe work in the meantime, right? And so when we reframe like that, that can kind of give people back their sense of dignity a little bit around sexual activity. And I have one more case to share. Everything's coming up all at once here because I forgot to add the animations. But Harry and Richard are a gay couple. And one of them, I believe Richard, has HIV. And this is often an ethical question of, well, can they, can't they? We're not going to get into that too much because, I really want to focus on the clinical skill building here. And, that's a separate kind of ethics discussion. But Richard says that he wants to enjoy being with his partner while he's still able to remember him, because we can see here that Harry has Alzheimer's dementia and a recent right colles fracture from a fall. But his BIMS is 11 out of 15, so he's not totally out of it just yet in terms of his memory, and he still might know who Richard is and is in the memory care unit at the same skilled nursing facility as Richard. So Richard uses a wheelchair. He's on some medications. He also has some comorbidities. And he has a below knee amputation, which is also important to consider here. And Richard is cognitively intact. So when we think about this, there are some recommendations as well, right? Thinking about that P, those person factors, what are those limitations and strengths? Since Richard can't stand, a seated position may be better, right? Because there's a fracture risk from osteoporosis, having all of Richard's weight on Harry should also be avoided. And so we kind of want to consider that. Are there any positions where that weight is maybe not full, right, on one another? And we want to encourage condom use for obvious reasons, the HIV and general sexual transmitted infection prevention in general. And then also considering the social work team and interdisciplinary team to schedule a time when they can be together privately. Once again, how can we make that environment look as closely to a private environment as possible while still maintaining safety, right? We also want to consider, how that environment interacts with those person factors. So it might make sense, because one person in this couple has dementia, for them to stay in their environment, right? Because we know that with individuals with dementia, they're more likely to get confused if they leave their environment, right? And so thinking about those interactions is also really important. And this PEO model can provide a framework for what interactions we need to consider. And so the take-home messages here are that sexual activity is a really complex thing, but with proper assessment and recommendations, this can be done regardless of patient condition. And that this model can help frame that thinking for us. You want to consult with your occupational therapy team to help figure out what sexual safety evaluations might require, further assistance or even rehabilitation. So in the case of the Johnny and Harriet case with the hip fracture, that's a post-acute case. And as a result, that person is receiving rehabilitation already, most likely. And how can that balance out with, okay, if they're getting rehabilitation, how can I involve that rehabilitation team, right? One really fun fact about sexual activity in occupational therapy is that it's a billable service. So if you're a medical director, your time is not likely going to be, reimbursed for considering all of these sexual activities. But if you're an occupational therapist working with somebody, sexual activity is an ADL and we're paid to assist with those. And so that's billable under the CPT 97535, which is the general ADL CPT code. And so that still applies here. So just like toileting, an insurance company legally cannot decline for those same purposes, because this is, if you medically justify it in your note around quality of life and function and safety, that there might do it anyway and be unsafe. Now you have a nice little case as to why the insurance company should pay for this. And so that's something to consider. And with that, I'm happy to take any questions anyone has.
Well, I kind of want to put out a question to the 43 participants. I'm wondering if anyone has a success story, whether it's a medical director, facility, a good positive experience in a facility, even if Chad with the Department of Health, if they've been through a survey process, we're like, wow, this was handled really well. This was a good experience. I don't see a ton in my facilities personally.
And I don't know if I don't see it a ton from my work because it's not there, probably not, or is it because I'm not asking? Probably more likely.
From the survey side, we come across it from time to time that people are in relationships, and we really want to make sure that we are recognizing and honoring that person-directed care, that people have a right to have these relationships. And a lot of times what creeps into that is the issue of consent and capacity and all of those kinds of things. And we have some regulation that speaks to sexual abuse, and one of the parts of the definition of sexual abuse is if it appears to be consenting, but one of the partners or more lack the ability to consent or express consent for the relationship. And from the regulatory side, that feels pretty cut and dry, but from the position that we respect adults and adult wishes and those kinds of things, we really look to see what the facility has done to support the first protect people, but secondly support the relationship and support people's wishes. And the thing with capacity or the consent, that could change on a daily basis. And really what we look for is the process, that there's a process in place. And then we, if people are being protected, we really don't delve too deeply into that from a regulatory standpoint.
And if I can kind of add to that, something that, when I originally started at the facility that I work at, per diem, something that I noticed was that on an admission report, on an admission eval, it would often say like sexual activity, and it'll just say not asked, right? And so as the clinician, if you're doing an evaluation, or if someone on your team is doing an evaluation and it's just not asked, you don't know if that individual previously fell into that 8%. So especially in like a post-acute or recent, transfer to your facility, even to long-term care, if that person is, say, coming from an assisted living with a spouse and they were having sexual activity, a week before, if you know that, then, the process for, is this a consensual situation, is oftentimes a lot more clear and it's documented. Whereas then if all of a sudden someone comes in and says, oh, well, I want to have sex with my partner, and there's no documentation of whether that was happening before because it wasn't asked. Now there's a ethical dilemma that, if asked on admission, really could have been avoided. And if a regulator were to come in and say, well, or a surveyor were to come in and say, well, what's happening here? What was the process like? There's nothing to point to, right? You just say, well, we have this ethics committee and we made this decision, right? But if you could say there's a clear line of documentation supporting this, you are on firmer ground legally as well, and ethically, because there's a line of evidence showing that you made the right decision. And so I would say that that's actually a case for why it's a really good idea to have those conversations early on admission, even if they can be a little uncomfortable. And they become less uncomfortable the more you have them.
Bob McCurry, I have a question for you. As a medical director of a psychiatric facility, we do have sexually active residents. Some are a younger age category. And how does that come up to a surveyor in the way of where it's documented, those sort of issues that would be brought forward in the first place to a regulatory standpoint? Just so I have a better sense for what we're doing at our facility in the way of documentation. And again, these are psychiatric patients too. They are seen by the psychiatrist. And so there's more than one physician making a determination if they have capacity to make decisions or not. But how would that be best documented, number one? And number two, is that something that surveyors are coming in and looking for a category to see that is occurring or not occurring? How does that rise to their attention in the first place?
So, when you look at the regulation, it feels pretty cut and dry in terms of the person appears to be wanting to have the contact, but lacks the ability to consent to that. We want to take that at least a step further and look at the process by which, first that the person is protected, but secondly, look at to see that the facility is engaged in a process. So our focus is going to be more about the process, more about the documentation. And as Ben said, the earlier in the process that you can start to document where a person is, what their wishes might be, one of the top things is sometimes is getting that input from family, and family said, mother would never act this way. Mother would never, this is so against, or not against, contrary to what she typically did. But that doesn't mean that isn't her want or desire now. And so we tread very carefully with that, but we would look to see that there's a process being followed. And in order for us to understand that process, to see that the facility has thoroughly documented not only the process, but an assessment of the person. And sometimes that can be tough because the person's abilities in terms of cognition may change from day to day. And so those things might need to be considered on a very routine, a very frequent basis.
Right. And again, speaking that, so what we did have was success from the standpoint of being able to honor the requests of two willing adults that could make decisions for themselves, and they were their own power of attorney. They had psychiatric disorders that required them to be in a closed facility, but when they were on medication, they were deemed competent to make their decisions. And there was a room that was designated specifically for sexual encounters for them that was not used for anything else, and only for those people that were sexually active within the facility, and that was carefully monitored as well. You know, again, it's just kind of that issue of someone taking advantage of another individual, depending if they're not on their medicine or not, if there's been a change in behavior, how they're leveraging. I get one of your cigarettes if I give you sex, you know, those sort of things. So in the psychiatric facility, that sort of, you know, plays into the same issue of, then are they really competent? They're manipulative. It's part of their disorder that they have that's kind of driving these behaviors. Is that a good monitor for, you know, is their disorder being adequately managed? Other aspects of their disorder may not be at the forefront, but their sexual activity may be, specifically like a bipolar patient.
There is a question in the chat, sorry. So I want to make sure that Ben gets a chance, and I'm paraphrasing, so if this person wants to correct me, but the question is, Harry is demented, and how do we determine if he is okay having sex with Richard?
That's a really good question. There are a few different ways to go about that, but the way that I would usually recommend is, I think assent is really important. And so typically there's a power of attorney for if he doesn't have, you know, capacity. And if that person is, you know, his partner, then, you know, sometimes for that specific thing, for in terms of like consent, a third party will come in and make that decision. And then assent plays a role as well. So, you know, his demeanor and or verbal confirmation is really important. And having someone like a psychologist or a social worker, or, you know, even you know, a medical professional go in and say, is this something that you're interested in? You know, if he's able to process that, is really important. I put the BIM score of like 11 out of 15 there, because that's kind of on the borderline of, he's still able to kind of process verbally some of what's going on around him and that kind of thing, and is likely able to respond to questions like that. And so it is a little less clear when you have a patient who has dementia, who may have a severe, you know, cognitive impairment. And then, you know, I would typically rely on what has historically happened. You know, are there any reports that this was happening, you know, prior? It's been my, you know, I don't know if there are any studies on this, but it's been my experience, you know, I ask my patients this all the time because I think it's important. And it's been my experience that people are unlikely to lie about their sexual history with their partner, because there's a lot of potential harm that can happen. And so unless there was, you know, active abuse prior, it's people are unlikely to lie, because the ramifications in this population of older adults especially are really clear. And so sometimes you kind of just have to take people at their word that they were doing this before. Usually if people are really pushing for it, it's because that's what they were used to, and they're struggling to adjust as well. And so sometimes just having a conversation with the partner is really important, and can give you a really good sense of their motives. You know, if they're like, well, we were doing this all of the time, and I'm not, what am I going to do now? Am I supposed to go out and find another partner? I don't really know if you know, and they're seeming conflicted, like that kind of shows alignment to their partner, you know, but they really have a strong sexual identity as well. And so having conversations is really the best way to determine that.
One last question I have, Ben, I think this has been a great talk, is I see at psych farm meetings, a lot of times they hear the patient's being hypersexual and they're going around and they're making sexual advances. And so a lot of times what ends up happening is they're on a medication to decrease that desire. Do you have any experience or any success stories where instead of medicating them, you give them an outlet or another way to express themselves? Because that's concerning to me sometimes when I see that.
Yeah, so I think it depends on the case. If you're talking about someone who is cognitively intact, I would say there's likely another aspect. There's like a psychosocial aspect going on, right? So maybe this is an individual who, lost their wife and is feeling lonely, right? Maybe this is an individual who, is struggling with their loss of independence. And so when we consider like the human side of that and what that person is going through, and this is why they're acting out, it can kind of become really clear that there might be a better remedy in terms of, well, can we provide this person with that outlet like we did in that first case with Sylvia, right? They might feel like I'm in this clinical environment permanently forever and I don't know what to do. And I'm taking it out on, whoever is around me. It's a really frustrating situation that our residents often end up in,
Right.
and so in that case, a social work consult might be really helpful. In the case where someone has a cognitive impairment, then, you kind of have to say, okay, well, is this happening as a result of the disease itself? And then it might be more appropriate for there to be a medication, right? Or is this happening because they're paranoid or someone else is making advances towards them and they're not sure how to respond, right? So you need to do a little bit more detective work in those cases to figure out what's the best solution for that particular case. So I know sometimes it's an annoying answer, but it depends.
Yeah, that's great. Thank you so much. I think we have Dr. Gahm on for our influenza update. Is Greg on?
Yes, I am here, Chris. It took a minute to get off of mute.
Great. Do you need to share screen or?
No, I'll just do this verbally and it'll be really quick. We're in good shape as far as influenza goes. There is just no influenza in the community. Hopefully staff are all vaccinated by now. Some people got anxious and I'm sure there's a whole bunch of residents that are vaccinated. My recommendation anytime going forward is fine to start residents. I hesitate because with COVID, we just never know when flu is going to get here. It keeps getting here early, but typically it doesn't get here till January, February. And the sooner we vaccinate these folks, the more that won't have protective antibodies by the time it gets here. But I think anytime in the next month would be fine for residents. Other things I wanted to bring up real quick in the vaccine world. The CDC is now recommending a second 24-25 COVID vaccine, a booster for immunocompromised and older folks, which really is almost all of our patients. My own recommendation would be, if you're just now getting around and you just gave it 3 weeks ago, wait 90 days, because they look like they're lasting 4 to 5 months, but by 5 months, they're virtually useless. So wait 90 days and give them their booster. And then the last, 2 more quick things. The ACIP and FDA just reduced pneumococcal vaccine recommendation, which would be, of course, now the only one you want to be using is Prevnar 21, also called Capvaxive. It should be the only vaccine you're giving. And it's now good for anybody down to age 50. So it initially was 65 and up, but in high risk groups, and now it's anybody down to age 50. And then the very last thing is that just about a month ago, for the first time ever, the FDA approved a vaccine through your pharmacy for home use for influenza. Won't be available this year, but starting next year, Flu Mist, which is the nasal vaccine, will be available at the pharmacy for home use. It still requires a prescription, but once you get the prescription, you can go to the pharmacy and take your vaccine at home. And it's not a shot. So that's it.
Dr. Gahm, I have a quick question on that. So we had that availability in outpatient clinics for a while, and they found that they weren't as effective as the vaccine. Are you finding that there's other evidence that the nasal spray is going to be as effective?
Yeah, the FDA looked at it pretty closely, and it was as effective. You know, my own, when this was big a couple decades ago, when it first came out, one of the things that we found was it stimulates a lot more IgA, which is the local antibodies. So in that regard, it was probably more effective. But one of the problems was it was sometimes so effective that it lasted into the next year and reduced the efficacy of the next year's vaccine. So at least all I can tell you is from personal experience with my family, we used to do flu mist 1 year and then the injectable the next year. We just alternate years. I don't know if there's any science behind that, but based on what I was reading, it seemed to make sense. But at least the data that the FDA looked at for flu mist was really good.
Good.
That's it, Chris.
Thanks, Greg. I think I'm going to let Dr. Pallet.
Yeah.
We have a few speakers or a few presentations for re-elections.
Yes, in the short time that we have left, I'd like to introduce you to 3 of our CMDA board members who are up for re-election as board members at large. We've been so pleased to have each one of these people bring their perspective, their expertise, and their resources to CMDA, and having this variety of voices had just make our board much stronger. So at this time, I'd like to invite Valerie Shade, Alicia Smith, and Raj Rai to come off mute, and each one of them will introduce themselves. We will send out a ballot to all of our current members later this afternoon, and you'll get a chance to vote.
Yeah. Are you able to hear me okay?
Yes, we can hear you. Thanks, Val.
Awesome. So Val Shade, I am a nurse practitioner with Longevity Health Plan. I work in several of our Vivage Beacon buildings currently. I have been a nurse since 2012, and prior to that, I was a software engineer. So I bring a whole lot of nerdiness to the role, and I hopefully a lot of, you know, just different perspectives, like you said. I am running for re-election. I think it's a very important role, and what we do is just so very important because, you know, we do have a lot of new people that rotate through these facilities, and they need a good resource. They need somebody who's connected and has, you know, this type of connection to come back and say, here's what, you know, guidelines are and how to best care for our patients in this extremely vulnerable community. So that's all I have. I know we're short on time. Thanks, guys.
Thank you, Val. Alicia?
Can you hear me?
We can hear you.
I'm Alicia Smith, and I'm a PA, and I've been a PA since 2004. And I've been in the post-acute long-term care area since 2005, so coming up on 20 years. So I have a lot of experience, and I have been on the board for the past 2 years and would like to continue serving on the board. I really enjoy the educational aspects, and I love the conference and help out wherever I can. And it's been a really great experience that I would like to continue doing.
Awesome. Thanks, Alicia. Raj?
Thanks, Singh. Yeah, Raj, right. Wound care physician here in the Colorado, Denver metro area. Been a part of the board for a few years now and really honored to be a part of it with everybody here. And I mentioned wound care, also chief medical officer for home health hospice company here locally as well. The question of whether or why post-acute care, I think, comes up, and I think it's kind of evolved over the years. I've been doing this for almost 10 years now, and probably the answer has probably evolved over the years more along the lines of certainly the networking, the ability to connect with everybody, learning so much on these calls as well, of course. But I think for the longest time, post-acute care has been more like almost like a stepchild in the healthcare industry. And having two new stepchildren of my own, I kind of want to change that perception. So that's why I stay in this community. So
Thank you so much. Great sentiments from all of you. We so appreciate you running for the board. Look forward to getting all the votes in. And thank you all so much for joining today's meeting.